Did you know that there is a silent killer lurking in your blood, affecting 1 in 5 people worldwide? It's called lipoprotein small a, or short LPA. And that one could increase your risk of heart attack and stroke by up to 4 times, even though you think you're healthy. Let's say it's like a little genetic time bomb that affects 63 million Americans. Many of them have no idea they're actually at risk. And according to the Copenhagen Heart Study, about 20% of the general European population have elevated LPA levels. In today's video, I would like to give you a more scientific breakdown of the topic about LPA. You will learn why this is a novel independent risk factor associated with heart diseases, what science actually knows about it, and which treatments are available, and maybe if lifestyle changes can help you to lower the levels in your blood. A big disclaimer in the beginning of this video. It's only for informational and educational purposes only, and no substitute for professional medical advice, diagnosis or treatment. The content that you will see, including text, graphics, images, are only information intended for general knowledge and should not replace a consultation with a qualified health professional. And very importantly, I cover everything more from the scientific perspective, so you understand what's happening actually in your body. I think the first question that you're gonna have is, Chandni, how did you come across this subject? Well, I saw a reel and it was talking about LPA and as an independent risk factor that you should get tested once in your lifetime. And it got me thinking, because usually when you talk about cardiovascular risk, you always hear, yeah, you have to measure your LDL cholesterol and so on. So I was really interested and left a comment there being like, do we have to also take into consideration all the other risk factors like LDL, for instance, the elevated levels, and the topic got really interesting. I didn't get the answer that I wanted to, especially afterwards when I asked for specific lowering medications, if there's something known. It was not really clear that there's something out there. So I thought, okay, maybe I should just read up and see where this is going. And I was really interested in it, so I thought I share this with you, what I found out from a scientific perspective. I think before we start, we all need to have like a basis. And the basis is to know what lipoprotein small a does. So I will give a little introduction into the topic so that you understand later on why it's important to have this measured and why this is an independent cardiovascular risk factor. Lipoprotein A is a unique particle in our bloodstream that has gained significant attention in cardiovascular research and is often referred as the hidden risk factor for heart diseases. When you now look at the cardiovascular risk, elevated levels of LPA has been shown to be an independent and causal risk factor for atherosclerotic cardiovascular diseases. It increases also the risk of heart attack and stroke and peripheral artery diseases. Also, LPA has been shown to contribute to the development of aortic valve stenosis. Now, when you look at the additive risks with LDL, high LPA levels compound to cardiovascular risk, especially in individuals with elevated LDL cholesterol or diagnosed with familial hypercholesterolemia. The combination of high LPA and high LDL-C significantly increases the risk of cardiovascular events. So in short term, people who have high levels of the LPA but also high levels of LDL cholesterol, they might have even more an increased risk to get a heart attack or a stroke. Now, when you look at the risk enhancement, when people have LPA levels greater than 50 milligrams per deciliter, this has been designated as atherosclerotic cardiovascular disease risk enhancing factor in the American guidelines, indicating its importance in risk stratification alongside traditional factors. And LPA also remains as a risk factor even with patients who have well-controlled LDL cholesterol levels, indicating its importance in residual cardiovascular risk. But there's also a discordance with LDL-C. So in some populations, particularly in younger women, there can be a discordance between the LPA levels and the LDL-C levels. So a woman under 40 with low LDL but elevated LPA may have the increased cardiovascular risk, emphasizing the need to consider LPA even when traditional lipid profiles appear more favorable. As I mentioned, your LPA levels are largely determined by your genetics, specifically by a gene called LPA on chromosome 6. You could think of this gene like a recipe book where it's written how to make the LPA. The LPA gene itself has a very special section that can repeat itself, so it's kind of like you're having a chorus in the song. And the number of these sections being repeated can vary from my genetics to your genetics. Now here comes the really interesting part. If you have fewer repeats, which means fewer choruses, in this section your body tends to make smaller LPA particles, but much more. Therefore, you will have higher levels of LPA in your blood. On the flip side, if you have more repeats, which means more choruses, your body makes actually larger LPA particles, but only fewer of them, so therefore you will have lower levels of LPA. So in a way, you could imagine that the genes are playing kind of the game of size versus quantity with the LPA, and your genetic lottery is playing a big role if you will have high or low levels of LPA. Now, when we come back to the analogy of a recipe book, the recipe itself comes also in different flavors and versions. So also so-called single nucleotide polymorphisms also play a role how these LPA levels will be elevated or not. When we talk about genetics, we also need to think of ethnic and population differences. So when we come back to our LPA recipe, we looked at our more individual level. So now I would like to more look on the global level. And this one, of course, varies depending on where your family comes from, what kind of background do you have, and the cultural tradition that is tied to it. So of course the dish will be influenced. If you look at African heritage, so your family has African roots, you might tend to have higher LPA levels. It's more like having more the spicier version of it. When your ancestors come from Europe, it could be that the LPA levels are most generally lower. So you could think of the more milder version of the dish. Now, when we look closely to the recipe books, we see for people from the European background, the almost differences that we see in the LPA levels coming from the variation in the specific gene, the LPA gene. So it's like one main cookbook that everyone uses. But we have a mix of flavor when it comes to the African heritage because it's more complex there. The LPA gene is still very important, but other factors and other genes that are important play also a big role. So it's like having like an additional cookbook and some, family secrets, some ingredients that are added that influence the final dish. But I would like you to remember, these are general trends. Just not every one of us from a certain culture likes the same food. So it's the same with the individual LPA levels, which can vary within these groups as well. Now we would like to know what LPA does actually in our blood. And it's like a little troublemaker in your bloodstream. You have to imagine it's like a little sticky ball that carries cholesterol and inflammatory substances. And this little sticky ball can easily slip into the walls of your blood vessels and starts there to cause damages, because once inside of this blood vessel, it actually acts like a little magnet. Cholesterol and inflammatory cells are really drawn to it, and over time you build so-called plaques, which can then narrow the arteries and make it really hard for the blood to flow smoothly through the artery. You have to imagine it's like a magnet inside the vessels, and LPA is not just sitting there very quietly. It actually triggers all the time the alarm of the body defense system. So constantly there is an alarm leading to ongoing inflammation, and that actually leads to a further damage of the blood vessel. And on top, there's another problem. Now it's getting tricky because LPA looks a bit like another important protein called plasminogen. And plasminogen is actually really important to break down blood clots when you need it to. But LPA gets actually into it because it's copying or mimicking it, therefore interfering into the process. So this means with high levels of LPA, you might have a harder time breaking down blood clots when you need to. And in very simple terms, LPA is like a double agent in your body. It contributes to the formation of plaques in your arteries, therefore causing slower blood flow, and can also interfere with your body's natural clot-busting abilities. Now you learned what LPA is and what it does. The next question is, how can we treat high levels of LPA? There must be a way to lower it, right? Right? No. Currently, there is no widely approved effective treatment specifically targeting high levels of lipoprotein A. However, there are several approaches and potential therapies that are being explored. Lipoprotein apheresis is the only FDA-approved therapy for now treating high levels of LPA, but it's limited to a very specific patient group with familial hypercholesteremia, high LDL cholesterol, and existing cardiovascular diseases. Another way is by using PCSK9 inhibitors. These drugs have been shown to reduce the LPA levels by 20 to 30%, but still the primary purpose using these inhibitors is to lower the LDL cholesterol. So therefore, they will be used to manage the LDL cholesterol and having LPA reduction as an additional benefit. How do PCSK9 inhibitors work? Well, these are monoclonal antibodies that bind to this PCSK9 protein. And usually this PCSK9 is used to break down LDL cholesterol receptors on your liver cell. How is the mechanism of action? PCSK9 inhibitors function by binding to free PCSK9 in the bloodstream. Then this prevents PCSK9 from binding to the LDL receptor on your liver cell and allowing more LDL receptors to remain on the surface of your liver cell. If you have increased ability of the liver to remove LDL cholesterol by binding and taking up the LDL cholesterol because you have more receptors, you will have less LDL cholesterol in the bloodstream left. In addition, there are other experimental therapies and clinical trials that are ongoing to reduce the LPA levels. Now, what's the current research on finding new ways to lower LPA levels? Ongoing trials focus on gene silencing. There are three powerful tools here to explore: siRNA, antisense oligonucleotides, short ASOs, and CRISPR-Cas9. They all behave like a little precise scissor with a unique approach to silence a gene. So how do these siRNA and ASOs work? When we go back to our recipe book, we don't want to have a certain recipe made. So sometimes we need like these little blockers, which were these siRNA and ASOs, to block the recipe to be made. We start with the siRNA, like a double team blocker. You have to imagine that the siRNA is like a tiny double-sided sticky note, about 20 to 25 letters long. And how does it work is that they stick to a special kitchen helper called RISC complex. One side of the sticky note guides the RISC to the exact recipe where it needs to block. When it found the recipe, RISC acts like a little paper shredder, cutting it down so it cannot be used anymore. In case of ASOS, we have the solo recipe stopper. So you have to think of ASOS as a single-sided sticky note, usually 15 to 25 letters long, and they have some tricks up in their sleeves. So usually what they do is they call a helper, and that one cuts up the recipe they stick to. In other cases, can cover up the start of the recipe so it cannot be read anymore. And also others can change how the recipe is put together or get in the way how the chef is trying to use the recipe. In some way, siRNAs and ASOs are really clever ways to stop specific recipes, so in that case the LPA gene, from being actually made in the kitchen and help to lower the LPA levels. In case for the CRISPR trial, it targets the LPA gene and knocks it out. So it means that the liver does not synthesize it anymore because the recipe for it has been shredded, so it cannot be read anymore. This siRNA is administered as single dose and reduced the LPA levels by up to 94%, with effects lasting nearly 1 year. And it blocks the LPA production in the liver and therefore is being now used in phase 2 trials. Another one that has been tested dose-dependent, reduced 46 to 96% and lasted about 150 days in the first phase 1 trial. Another one reduced the LPA levels by over 8% in a 36-week phase 2 trial with minimal side effects. One of the ASOs has been tested in a phase 2 trial and it reduced the LPA levels up to 80%. Right now in a phase 3 trial, the Horizon trial, they are trying to evaluate the impact on cardiovascular diseases. Now, scientists thought, how could we increase the efficacy of LPA reduction? And they came up with a tiny high-tech eraser for your body's instructional manual. And this eraser is called CTX320. And this one is designed to remove specifically the instructions for the LPA in your liver. Here's how this amazing little eraser works. First of all, the special delivery. CTX320 comes in a lipid nanoparticle, which means it's made of a little tiny bubble made of fats and kind of has a microscopic water balloon. And it contains everything that it needs to sneak into the liver cells. Then we have the precise editing. Once inside the cell, CTX320 uses the tool CRISPR to find and erase exactly the information to make LPA, so it destroys the recipe. And it's a one-time treatment. So once you have taken this and in one dose, it potentially reduces the LPA levels for a very long time. So before we could go into human clinical trials, scientists tested CTX320 on monkeys and found out that it lowers the LPA level by a whopping 95%, and the effects lasted for over 1 year. And the animals tolerated it well, so there were no major side effects. And what's happening now? As of February 2025, medical professionals are getting ready to test CTX320 in human clinical trials. And this is kind of very special because it's the first time they have used CRISPR to lower the LPA levels. And if CTX320 works well in humans, as we have seen in animal models, it could be a game changer for people with high LPA levels, potentially lowering the risk of heart problems with just one treatment. Although LPA levels are governed by our genetics, I asked the question if diet and lifestyle changes can or cannot influence the LPA levels overall. And recent research suggests that certain lifestyle changes may help to manage LPA levels. And here's what I've learned from studies on obese people. So significant weight reduction in obese people with high LPA might lower their plasma LPA levels. So one study found that 10% decrease in LPA after vertical sleeve gastrectomy in obese patients with metabolic syndrome. When we look at the diet composition, there was a study with low-carb diets, so a 20-week study on overweight and obese patients, and they showed a reduction of 15% of LPA with a diet composed of 20% carbs and 21% saturated fats. In case of saturated fats, they found out that the diet with higher saturated fats lowered the LPA by 8 to 11% compared to diets high in trans fats or oleic acid. And in case of trans fats, it's said in the study that to avoid these, since they increase the levels of LPA. When we come to physical activity, some studies suggest that it may help to reduce the levels, but more research is needed. Please, it's really crucial to note that these findings are primarily from studies on obese individuals. The effects might differ in people with normal weight and different health conditions. More diverse studies are really needed to understand how these lifestyle changes affect the overall LPA across different populations. While these changes show promise, factors, the impact on LPA is generally modest compared to genetic factors. However, adopting a healthy lifestyle is still very beneficial for your overall health. Alright, let's wrap up our journey here through the fascinating world of lipoprotein A and why it's so difficult to target and lower the levels. Now we learned that LPA is like a family heirloom that's passed down and through generations and can have a big impact on our heart health. And it's not something we can easily control through diet and exercise, which makes it uniquely challenging in the cardiovascular medicine. We explored how LPA levels can vary among different ethnic groups. It's kind of like how traditional recipes might differ across cultures. For some, the recipe is very straightforward, while for others, it's a bit more complex with additional ingredients involved. While it is very challenging, we have uncovered in this video together what researchers are right now working on to effectively lower the levels of LPA. And therefore we dove into the exciting world of gene silencing, where siRNAs and ASOs acting like librarians deciding which genetic book should be read. These techniques are opening up new possibilities for managing LPA levels. And we have, of course, our CRISPR star, CTX320, a cutting-edge CRISPR therapy that's like a precise eraser for our genetic code. So it aims to stop the LPA production at its source in our liver, potentially offering a one-time treatment for a long-lasting benefit. While genetics play a big role, we shouldn't overlook the power of lifestyle changes. Recent studies, especially now in obese people, suggested that weight loss and certain dietary changes might help to manage LPA levels. But however, we need more research to understand how these changes affect people of all shapes and sizes. We need more nutritional studies on LPA levels, and therefore we need to set up certain experimental parameters, for instance, different backgrounds, ethnic backgrounds, different populations, but we also need to know what are the levels of each individual. Do they have lower or higher risk? Also the genetic background, what's the proteomic background, so it means what is the overall protein composition, what are other risk factors that come into play, and that all needs to be evaluated. So we cannot jump on one study and be like, oh, we need to change the dietary pattern of these people. It's more likely to assess what can be done additionally. And I think in this case, as already the research shows, we need more targeted approaches, in this case targeting the genes, because it's more likely a genetic problem that we have for the people who have high elevated levels, to get the levels down, so the cardiovascular events risks are also getting lower. So it's a difficult and very complex situation to take into account many different variables before we start maybe just changing your diet. As I said in the very beginning, of course, always speak with a health professional about it and get the best consultation about this. Remember, whether it's through groundbreaking gene therapies or making healthy lifestyle choices, every step counts and towards a better heart health. The future of LPA management looks promising, with science paving the way for more personalized and effective treatments. Thank you for joining me on this exploration of lipoprotein A. If you found it very interesting and exciting, please leave a like and subscribe. What was your favorite piece of information? Let me know in the comments. As always, let a little dose of honest science in your life and brighten up your day.